I'll ask you to screen share, Dr. Coey. So welcome everyone tonight for what is our sixth Nestor session of the year. Tonight, we're honored to have Dr. Maureen Cohey join us. Dr. Cohey is a professor of radiology and chair of the Department of Radiology at the University of North Carolina School of Medicine. She's a graduate of Stanford University and attended medical school at New York Medical College. Dr. Cohey completed a residency and her fellowship in interventional radiology and vascular interventional radiology at UCSF. And her clinical and research focus is on women's health and interventions. She's a very accomplished researcher with over 70 publications. And Dr. Cohey is also a national leader in IR with many leadership positions, including an executive council member for the Society of Interventional Radiology, development division chair of the SIR Foundation, scientific chair of the SIR annual meeting, associate editor of JVIR, chair of the Women in IR Governing Council, and member of the Vascular Interventional Advances Physician Board. We're very honored to have Dr. Cohey here to speak on an important topic. And so please join for what promises to be an interesting and informative talk. Any questions, please type in the chat box. And just as to note, after the talk, we have some case presentations. We already have 3. If you have a case, please just message me that you have one. You can direct message me. So without further ado, here's Dr. Cohey. I'll stop sharing.
Thank you so much. It's just such a pleasure to be here with you all. Give me the mandatory thumbs up if you can see my slides. Yes, okay, great. Again, it's just such an honor to be here. I really wish that I was with you all. So many of my dear friends and colleagues, I have learned so much from all of you on this call. You all know who you are. So I just wanted to leave all, judgment at the door and just enter a safe place and talk to you a little bit about IR complications and my perspective on them and how we cope, when we experience them. So with that, I don't have any disclosures. I have worked really hard to get to this slide, by the way, so no disclosures. I think that as physicians, we have a double bind, and we all know the Latin word, phrase, which I'm going to butcher, of the primum nocere, which is first do no harm. We all recited that really in an excited way in medical school, but quite frankly, to err is part of the human experience, which I would argue and agree with the author, that is an existence marred by miscalculation and misjudgments. And so the two of these are at a constant, battle with each other. How are we as physicians expected to be superhuman and transcend the level of humanity, but at the same time know that our mere existence is flawed? And so this is something to just, be aware of as we go through the talk and as we go through our days. Now, when we talk about complications, in this talk, I'm just going to put everything under complications, but, you all should know that there are very distinct terminologies involved here. So adverse events, which include complications, are different than medical errors, which are different than they're different than near misses. And so, well, what's the difference? So an error implies that a mistake has been made. Versus complications, which can happen even if everything has been done correctly. Now, we all know that complications, we typically in our M&M say this is an expected complication. You do a TIPS without IVUS and you puncture the liver a bunch of times, the patient can bleed, and that's, expected. You place a port and the patient could get a port infection, that is expected. But while I think these concepts are dissimilar, I feel that the feeling that we encounter when we come back and we realize that the really difficult TIPS patient bled a lot and nearly died, or the port person like had to have the port removed and undergo antibiotics, we still feel just as badly as we did if we had done something technically incorrect and caused a complication. So I think what we're left with at the end of the day is still that same guilt. Mentally, maybe we feel differently, but I think emotionally, it still takes a toll on us. And there are a variety of different ways of classifying complications and medical errors, whether it's technical, whether it's your judgment, whether, how you respond to it, what kind of ethical approach you're taking. I really think that, again, these are things for all of us to, be aware of. But I got to tell you that when it comes to our feelings, as I go through the cases, it really doesn't matter a whole heck of a lot whether it was technical versus judgment versus whatever. You harmed a patient, right? You affected their livelihood or their family and their emotions, and that takes a toll on us. So with that, I wanted to go ahead and share with you some cases because we're going to talk about those at the end anyways. So this is my first case, and it's a case of a 59-year-old female with a history of locally advanced adenocarcinoma of the pancreas, so ampulla of the Vater. She was diagnosed in 2016, so it was a way long ago, and she had biliary and gastric outlet obstruction. She underwent stent placement for decompression. She had chemotherapy and radiation and went into remission. And then completely separate from that, she, in 2 years later, developed refractory ascites, recurring paracentesis, and she was diagnosed with what ended up being a fatty liver NASH-related cirrhosis. And she denies, lower extremity edema, confusion, GI bleeding, jaundice. And so I saw her in clinic, and the consult was, paracentesis and a TIPS. And, that's probably my favorite procedure. So I was excited to see this patient. And when I looked at her images, this was what I saw. And lots of stents, a lot of communication of the biliary tree with the enteric, with the enteric organs. But gosh, to look at that window, I mean, that was that was a straight shot from the hepatic vein to the portal vein. And I spoke with her and I told her about the risks, benefits, alternatives. I talked to her about putting in a PleurX catheter, and her quality of life was that, she wanted to walk, she wanted to be out, be outdoors, and she just didn't want to have a catheter hanging out of her. And she knew the risks of doing a TIPS in light of this connection right here, but she wanted to go for it. So like any other, person who doesn't operate in a vacuum, I asked some of my colleagues and I said, well, what should we do? And got a variety of responses, emphatic, don't do a TIPS. Are you out of your mind? Why don't you just put in a tunnel drainage catheter? And then I would say, well, I mean, she likes to garden, she likes to hike, she likes to play with her grandkids who would be pulling at this thing. And then I would, hear things that weren't really based on evidence, like put a TIPS but uncovered stent, so if she won't get TIPsitis. And then you think about the fact that, could people only with a PTFE covered stent graft get a TIPsitis? Can't they get it if it wasn't covered? I mean, I'm not sure, that the studies are really poor. And then, you should just load her with lots and lots of antibiotics and clean her gut and then place the TIPS, which is uncovered. And I'm like, really, is there good evidence to support that? I don't know. And then finally, someone somewhere who said, just go ahead and put a TIPS, Maureen, just use a Viator. Like that's what we covered TIPS. That's what you should do. Okay, so I did the TIPS. It was technically not that challenging. Felt, great about the procedure. She was happy. Her husband was happy. And then the next day, of course, she is febrile. And she's bacteremic, and then they do a CT, and there's some low density around the stent, and that doesn't make me feel so great about anything. And then a couple of days later, There's an ultrasound that's done and there's no flow in the tips, and there's complete occlusion of the tips. And so just to further document it, they got a CT and it was completely occluded. So obviously I don't feel so great about myself. This is a complication. Tips do go down. And what we do is we go back in and we do what's called a tips revision. I mean, it happens not too uncommonly. And back in the day, it was the thing that we used to do before the stent graft covered tips, or before the PTFE covered stents. So I think about the case a little bit more as to why this happened. And I go and I review the images, and I was like, oh gosh, like my tip stent, my Viator, the uncovered portion is too short. I mean, I should have landed it a little bit deeper into the portal system. And maybe in the process of landing it here, there is some bile leakage into the shunt, which is causing the thrombosis. And so, okay, no problem. I'll just go back in. I'll, thrombolize this, and then I'll line it with a brand new tips and, stent, and that should fix it. Except in the workup, which was massive, that she underwent because of bacteremia and this and that, and they were worried about, heart vegetations and things of that. We found out that she had a small PFO. Okay, so she now has a right to left shunt. And what I'm proposing is to go in and thrombolize this, tips, which we would do anyway. On an outpatient, I've done this so many times. I haven't even asked for an echo to see if she's got a right to left shunt. So there was a second debate, but you know what? So many people could not wait to tell me how wrong I had been to even do this in the first place. So I told you so's, and you should have thought more about this. And then, like, out of nowhere, something's clotted, we should just anticoagulate. And I was thinking to myself, like, how is that going to help? But maybe it would, I don't know. And then, of course, the person who first of all said we should place a tunnel dialysis catheter, like, why don't you place a tunnel dialysis catheter? And as if this never happened, as if she's going to be on antibiotics forever. And then, of course, the thought of what you would have done anyway. Maybe we just do thrombolysis. We just try to get through it and reline it, and just, put in brand new tips in. And then, of course, WWJVD. And this is the most unfortunate thing about giving virtual conferences, because I can't call anybody to suggest what WWJVD is, because it's really, what would Jim Benedotti do? And Jim is one of my all-time mentors, and he just gets it. And so I got on the phone with him, and I explained the situation, and he's just like, you know what, Maureen, just go in there, lice it, and just, put a new tips in and call it a day. Because the PFO is probably not going to be that big of a deal. About a third of people walking around have a PFO, so just go ahead. So that's what I did. I went in, probably an overkill. I could have just, placed the tips right here and there, but I liced it. The next day looked beautiful. You can again see that it's short. And so then I relined it, and she did great. And, you can look at this chart and you could probably think, well, maybe it's most certainly is a technical error, because my tips was too short. I should have paid more attention to the fact that the uncovered part of the stent was not in the portal vein, and I had dragged it too hard. Fairly aggressive when I do procedures, so I probably pulled it way back too much. But ultimately, I felt pretty terrible. I mean, this case ended up being a save, but it did make me understand that to err is to be human. I'd done so many tips before at my institution, yet, having patient-centered care delivery can be complex. You could have argued that I shouldn't have done this in the first place. I bet there's someone on the call who thinks I shouldn't have done this in the first place. And it's okay to ask a lot of people for their opinion, but ultimately it's your patient, your decision, and ultimately your complication. And it's really great that she did well. And, after a course of antibiotics, everything worked out for her in the course of that therapy. But I got to tell you, like, I was very, very, distraught about what I had done to her, should have done that. Why did I, in the first place, putting at tips, and more importantly, like why was the tips too short? I'd never done such a thing before. And so the ultimate emotions are very real and devastating, even though ultimately things work out for the best. Now, the second case is a little bit more different, and it actually, talks about something we were talking about in the very beginning of this session before everybody joined in, of what do you do, how do you avoid complications when you're very junior? And I could tell you that this case is a case that happened to me when I was very, very early on in my career, and it was in the very beginning of my second year of being an attending. And this woman was extremely sick, just multi-organ sickness, so many comorbidities, cardiopulmonary, very little reserve. And she had developed new onset failure, and she had been spending a month in the ICU and just getting into renal failure. And so finally, and also she needed a IACD. And so what they thought was, let's put in the tunneled line before EP goes in to muck around, just because if you place the tunneled line after all those leads are placed in, then that could be, a little bit more precarious. So the consult was very simple. I mean, think about how many times as IRs were asked to put in a tunnel dialysis catheter. I mean, it is a very simple procedure, not much, brain power involved. This, like I said, is not, you're not doing downhill varices, embolizations through a TIPS or things like that. Certainly nothing like that. But the debate here was, gosh, she's got too many comorbidities to safely administer moderate sedation. So, it's best to just get anesthesia support. They can monitor her, maybe they can give her a little bit of something to take the edge off. And that sounded like a great plan. But remember, like EP really wanted to do their part. And if I wanted to get anesthesia at the time, I'd have to delay the case the next day just because of the available resources for anesthesia. And, when you're early on in your career, you just have so much of a pleaser complex. Like you just don't want to do that, right? You're letting down everybody. So then I was like, well, why don't we just do it with local? I mean, I've seen that happen before, and I'll just give her a ton of local. And then what I'll do is I'll just provide a lot of TLC. So I will be there. I will, and I talked to her about this, and she wanted option 2, and she just wanted to get this done and, be on her way to recovery. And that way I could do the case the same day, and then cardiology could do their part. I didn't have to utilize anesthesia. It would be a slam dunk. And, it really is important to just pause and remember what we are here to do. As physicians in an academic medical center, our role as IR faculty is to supervise, right? So we are in training institutions. Our role is to be supervising attending. And I just point this out because there's a purpose. I think that IR is like a dance. Everybody has a partner, and we just sort of go about in this beautiful rhythm. And when you violate that rhythm, bad things can happen. And so this is a picture of me back when I was a fellow, and I'm clearly the trainee. I am being supervised beautifully by my supervising attending, and there is an amazing nurse who is, completely focused on the patient and can at any moment interrupt us to let us know that something's wrong with the patient. And this is the dance that is successful. And if you violate this, bad things can happen, or bad things may happen. And so what I decided to do was to violate this, social decorum, so to speak. And so I was on the complete opposite side of the blue drapes. I had no visibility as to what was happening during the procedure. And I will never forget the conversation I had with the patient and how I truly put her at ease throughout the entirety of the case. And the catheter was placed in, again, like fairly smooth sailing at this point. And things looked okay for the most part. And then I heard, these words, which again are often spoken when we put in a catheter that may be slightly longer than we want, or they seem longer than we want, or maybe it's perfectly positioned. And the words were, take a deep breath. So the patient did. And from across the blue drape, I heard the sucking sound. And if anyone has heard an air embolism, you know exactly what I'm talking about. So I immediately, I felt like I popped over to the other side. And I found that both lumens of this 13.5 French tunnel dialysis catheter were unclamped, not flushed, and certainly not capped. And what followed, you can just imagine, obese patient with an ejection fraction of about 15%. She became unresponsive rather quickly. We called a code blue. An hour of resuscitation followed. She finally regained somewhat of hemodynamic stability, and she was readmitted back to the ICU from which she came from. And she was making good headway. She was cooled. We have this protocol, and she was making some recovery until she became really hypoxic. And the thought was that she had a PE. Unfortunately, she was too unstable to be scanned, and empiric anticoagulation was started. And unfortunately, she suffered an intracranial hemorrhage as a result of that. And the family chose to withdraw support. And this, hand in the face or face in the hand emoji feels a lot different than the first one, just because there's no save here, right? And you can, go through these charts again, and we can be pedantic and, ivory tower and say, well, maybe this was a judgment, medical error, and what was the medical ethics here? I got to tell you that it was just complete agony, right? It's utterly terrible when you are the cause of the loss of someone's life, and especially if you feel like you're a pretty competent person, then you immediately lose all confidence. The amount of guilt and shame and the depression that follow, it's just completely unexpected, because you've heard of these things happening and you just assume that as a person you're able to deal with it much better. And the lessons learned here are fairly simple. I bet you all know this. Is your job as a supervising attending is to supervise, right? Like, it's nice that you want to be, a lovely, caring physician, but first you need to supervise and make sure that things are going according to plan. And that ultimately, whether you're in the room, out the room, like wherever, on the right side of the blue drape, on the opposite side of the blue drape, this is your responsibility. Everything in the room is your responsibility. And then, as I said earlier, no case is too little to cause harm to a patient, no case. And it's oftentimes, I feel that we are so well prepared for those big, bad cases that we've just thought about everything that could go wrong. We've talked to the world's experts on it, and we're so prepared. Whereas it's, a paracentesis or a thoracentesis or a little biopsy that ends up causing a life, or severe adverse events. So I think, that the most important lesson, which we always talk about, is to learn from our mistakes, right? Even as children, we learn from our mistakes. And unfortunately, I just feel in a field that's procedure based, you're never going to have mastery over it. Maybe you can curb the mistakes, but they're still going to happen. And it's just the manner in which you respond, and the amount of luck that you have, maybe that's going to be different. But, a couple of things that I wanted to bring up in this case, is how to go about, disclosure. It's really important when things like this happen to make sure that you contact your office of risk management and you speak to them and you notify them right away. They're there to offer you guidance. You need to contact your supervisor, whether it's your chief or your chair, or your attending, and let them know. Nobody likes those kinds of surprises. And then I think the most important part is also to disclose to the patient and also their family, what happened, how did it happen, when did it happen, why do you think it happened, who was involved, and what are the consequences. And risk management will be crucial in guiding you through these questions, which the family and the patient will inevitably have. And my advice is to just be honest and humble and take responsibility. I think this is when sometimes people recoil and worry about malpractice, lawsuits, things like that. But I think there's no guarantee in anything. There's no guarantee if you're just super nice, I'm so sorry, that someone's going to say never mind. There are papers written about that honesty up front, taking responsibility can result in fewer litigation, but I just separate that so quickly from my mind that that's not why we're here. And we just want to very openly and in a humane way, just, discuss what has happened. And then I would advise you about chart documentation. I've seen this so many times when something has happened and people go back into the chart and back time their note just to try to cover things. And all of that comes out, all these epic note stuff, you can tell, even though you tell the computer that it's 8 p.m., the computer knows it was 10:20 p.m. So just don't do that, finger pointing, well, I told the nurse, or I told cardiology, blah, blah, blah. It just doesn't do you justice, and it will just bring you lower than where you want to go, and certainly lower than where you would end up. So I'm just always, very careful and very honest, and again, take the guidance of risk management. I think something that I've come to learn is about the second victim syndrome. And this was first described in the 1980s, which sounds like a long time ago. And it was this landmark New England Journal of Medicine publication called Facing Our Mistakes. And David Hilfiker is a family practice physician who talks about the devastating effects of medical errors on healthcare providers and how we feel victimized or traumatized by the adverse events. And how these second victims, because the first victim is the patient and the second victim is us, is left to cope with the feelings of guilt and shame and anxiety, while also trying to question their competency, to provide care in the future, let alone dealing with what's happening from the external world of people judging them and questioning them. And what is reported as 10 to 40% of care providers will experience this, but I'm willing to bet it's way more than that. And these are some of the emotions that folks feel, and I could tell you during my incident, I felt every single one of them. And it's a matter of, what time in the day it was, whether it was extreme fatigue or just super decreased job satisfaction. And what ensues is very easy to figure out, like depression, burnout, a feeling like that of post-traumatic stress disorder, which can really negatively alter this provider-patient relationship. Lots of people are put on guard because of this. And it also, depending on how this scenario goes down, can also affect future reporting. Maybe you're so harmed and traumatized by this, because it doesn't end there, right? Then the hospital gets involved and there's a root cause analysis, and then there's a departmental reporting, and maybe it reports to the state, and then there's litigation. It's just, this awful gift that keeps on giving. So it will affect, potentially your ability to report future near misses or medical errors, which really curbs the system-wide improvement that we want to pursue. And when you really want to think about it, what ends up happening is there are several stages. This is very similar to, depression or loss, there's the initial chaos and accident response, like you're trying to figure out what happened and help the patient. And then you step back and then there's this intrusive reflections of what if I had done that, or what if I had done this? You reenact, you ask a lot of questions, of yourself. Then there's some sort of restoration of personal integrity where you try to go to your peers and again, like you worry about how other people are going to see you. Are they going to trust you again? Is the service ever going to want you to place in another line, or are they going to, be okay with you doing another, big case? And then this enduring inquisition, which we talked about, at some point, the hospital gets involved and, potentially, it goes to litigation. And then the emotional first aid, where you really are seeking emotional support. And I will talk a little bit more about this. And this is something that I'll tell you is not very, it doesn't come in very handy. Like it doesn't come in very, easily to us, where we see, someone having suffered an adverse event or complication. We talk about it in our M&Ms, but then, I think there is this feeling that we should just never talk about it again, right? Like you don't go up and be like, oh, hey, John, like, I'm sorry you did like 20 stabs at the liver to do the tips and the patient bled to death. Like, I'm sorry about that. Like, you just don't want to talk to John about tips ever again, So that's the natural feeling. We just want to avoid these people, but maybe that's not the right way, because all they want is to talk about it and for someone to say, I've been there. I know how you feel, like X, Y, and Z. And I think the moving on is a really interesting phase, because we end up losing some of our colleagues to this, whether we lose them because they just drop out and they just go to another profession, or they stay, but they kind of drop out and that they change, they're not as emotionally involved in their work, or they're just guarded forever. And they're just, they become different. And then I think the third subtype of that is thriving. And it sounds bizarre, like how could you thrive as a result of a medical error or complication? But I think that's when you grow from it, right? You learn from it and you try to comfort others who are going to go through it at some point or another in their life. In terms of how you get up, how you move on, I love this quote, because falling down is an accident, but staying down is a choice. And I really believe that, because at some point or another, we always will fall down at some point. I had this great attending, Roy Gordon at UCSF, and he always said, if you don't want complications, don't do procedures. And it's true. At some point, you're going to have a complication. It's just, how are you going to get up? The choice you make to stop, staying down. And so the manner in which you do this is you got to cope, right? You got to figure out some sort of social support, some sort of accepting the responsibility of, what you did or you didn't do, which led to this near miss medical error adverse event. Like we talked about, folks distance and they become, very emotionally guarded, and escape avoidance, where they just don't want to talk about it. It's as if it never happened. They hide from it. And then the planful solving of how you're going to troubleshoot through this process. And some of the coping strategies, again, are, as physicians, we all know in concept these things. I guess the challenge is, are we going to take time out of what we're experiencing to take care of ourselves? Are we going to say, you know what, I just had this terrible complication, I'm going to take a week off and I'm just going to rely on my family or friends or colleagues to help me with this loss? Am I going to focus on mindful strategies? Am I going to take up a hobby, or am I going to go on runs or yoga or something to try to reflect upon the fact that I'm human and I made a mistake and it's terrible, it was devastating, but I still am human and I'm allowed to make mistakes. We all know what to expect in terms of we know to suggest or we know to seek counseling, but I think so few of us do. When you look at just about every institution, it's wonderful how many resources are available for people to go and talk about what their experience, support groups, some other folks. But it's just really hard to get to that point because you just want to, hide from it. And I think the last thing which we talked about is to try to find a way to support others as they go through this process, because invariably you're not going to be the only one in your practice or in your hospital that has a terrible complication. Other people will also feel, be in the same shoes, and it's how you're going to be able to help them that in a way helps you, sort of redeem yourself with respect to what has happened. And so sort of ending on that note, my mantra, which, is certainly not super unique, is that I know that I'm not perfect and that I make mistakes, far too many that I want to remember. But I really try to redeem myself by trying really hard to learn from those mistakes and not let them happen again. And with that, I will, draw this talk to a close and see if you guys want to talk about anything else.
Thank you so much for that talk. I guess I have one question to start, and then I would encourage anyone to type questions in the chat box or to just ask a question verbally when I'm done. I was wondering, you talked about, how you deal with complications yourself now and how you also try to help others, by bringing them up. But I was wondering more, I think at Brigham where I am now, we have a really good culture, where we openly discuss complications at M&M, and I don't think there's shame in it, and it feels very good. But I was wondering if you have tips in terms of establishing a culture, in the IR division or radiology on complications.
Yeah, I think one of the things that I noticed is that when young faculty join and they have complications, they oftentimes can be defensive, and they try to explain, like, no, it happened because of this and that, and like back where I trained, we did this and that, and I think that sometimes what happens is, particularly when you have super young folks joining, and then you have very well-established folks in the division, there's the people who've been there for so many years are like, listen, man, like you shouldn't do, blank blank. And then the young guy or the girl is like, no, but I saw this happen and it worked out. And there's so much excitement and enthusiasm. And I think that's a good point, good place where you just sort of say, like, time out, like, this isn't necessarily because, they taught you wrong at your institution or we're doing something wrong. It's just that not every time you do something that's different or the same, it's all going to go well. And so I think, like, trying when people start to get more defensive, I just stop it right away. And I always remind everyone, like, we're here, from a place of good. We're here to learn from each other. And this is really like what's going to help us when we have additional complications. We remember this and we remember the support. So I think that, and I think something else is the manner in which M&Ms are done. I think it is really great when, like, the person who did the case and suffered the complication is the one presenting it. And the culture is that of, we already know how we're going to grade it. Like based on every system, you have to say this was an expected complication or severely adversely affected patients, blah, blah, blah. And I think it's good to teach faculty to just summarize. And like, I've noticed that most people, almost everybody, when they do that, is that they just openly take the blame, which isn't say that's the bad thing, but or that you should force me to do that. But it's like, either like, listen, like I messed up here. Like I put in a tube and I looked like it was a pleural effusion, but it was the spleen. So yeah, I put a tube in the spleen and I feel terrible about it. It was a technical error. We figured it out. The patient actually didn't have much complications. But boy, I feel crappy. And next time I'll do blank, blank. Like that is much better than like, well, I don't know. I mean, like it looked like a fluid, dense fluid, and I don't know how it got in the spleen, like the fellow, blah, blah, blah. Like, I think that's bad when people start to explain things and blame other people. So, and I think, you know, as much as like other folks in the group can also be helpful and be like, yep, you know, like been there, done that. You know, I put a tube in the colon, like I was the chief of a section, and I'm like, yep, I certainly did that under CT guidance. I don't know how it happened, but I certainly put a 12 French tube in the colon, and I felt terrible about it, but it ended up being okay. But it was my error, and I think like leaders need to be open about that and not so defensive.
Great. Thank you so much for that response. Any other questions?
So Ezra, if you don't mind. Hi, Maureen. Excellent talk. Thank you very much. Awesome talk. Yes, definitely. I hope that has some alcohol in it. So one of the things, or two of the things I think are very important are that the concept of moving from M&M to peer learning and de-escalating or making the whole process of case review less targeted and punitive and more working towards a culture of learning. And I think one of the hard things that people have is coming, if they've come through a surgery residency or a surgery transition year, of that culture in surgery of you did it, you killed the patient, you have to suffer in public. And to move to a point where it's a learning experience and a supportive experience. And I would hope that other institutions, I know in Boston, there are a number of institutions that are moving towards just culture and peer learning. It's a huge cultural shift in your head. But the one thing I really wanted to get across that I find really hard to teach residents, fellows, new practitioners is that there is no obligation to death by IR. And one of the things that we have to move beyond is our own machismo of we must ride the horse into the sunset after saving the town, okay? We are valued consultants and clinicians, and we have to believe in ourselves that we can be a consultant. And sometimes the answer is it's in the best interests of the patient to not do something, because our inner soul wants us to create something wonderful and unique and save the patient. And yeah, we do that a lot, but we have to feel deep in our soul it's okay sometimes that we can't fix everything.
That I think that really resonates with me. And I think that, you know, there's that little like memoji or whatever it's called that says interventional radiology is like surgery, but only magic or something. And I think that we are so used to being like these MacGyvers and you know, it's hard. I certainly have been in a situation where I've just been like, no. And they're like, excuse me, what? Like, I don't understand what you're saying. And I'm like, no, we can't do this. And they're like, no. You're not allowed that. Whereas you look, surgery, you know, our surgery colleagues are like too sick for that, too old for that, not stable, blah, 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 you know? And it's like, well, wait a minute. So I think what is coming as we are growing as a specialty is ethics. And I think that more and more we're learning about the ethics behind IR. And do you take a liver that's like almost entirely filled with mets, and do you still put that patient through some sort of local regional therapy and just make them sicker and sicker so that the few months they have left, they're just, you know, in bed and just like miserable? Or do you say, no, I can't, and you know, you should go and do whatever it is you want to do for the remainder of your life? And I think the machismo is so true, you know, like, and I think no, and being okay with saying no. Now, you know, not to say no to like, you know, simple procedures, but just to say, listen, no, like we shouldn't do this. And I do feel that there are plenty of us who've written about this, who talk about this, that we need to bring in ethics into, and that's why I wanted to show that slide, is that, you know, ethics does come into this, and there are certain patients who are going to suffer really badly if they go to IR, and we need to be okay with them, with ourselves saying no, there's nothing we could do. It's a great point.
Thank you, Neil, and thank you, Dr. Cohi. As a young attending, I certainly do find it challenging to say no. So, you know, it's always good to get reinforced for that. Herschel, I know you have a question. I see your hand raised.
I just want to make a brief comment. I want to thank you for this address. It was wonderful. I find that for myself, it's important that I learn from the mistakes, from the complications, but I learn the right lesson. And sometimes I think we can be haunted by the complications. And I think it's important try not to get into that space. When I was a trainee, we were just putting in a G-tube one day, a percutaneous G-tube, and a T-tac just got placed too deeply. It just got placed too deeply, and we didn't have attending supervision. And I think there was some commonality to the case you were discussing. And I found out last year for a patient that I put a G-tube in, after putting scores of G-tubes in, I was putting a T-tacs in too superficially. I wasn't going deep enough into the stomach. I was so haunted by that complication. I was actually putting patients at risk for a different complication. So I just wanted to put that out there, that, you know, there has to be some balance, and you have to find some way to kind of live in that sweet spot. I also think there are some of our colleagues who are doing IR as the only interventionalist, or in departments where there might not be enough peer support. I think it could be great for SIR to develop a panel of people who would be willing to be peer support mechanisms for our colleagues that might not be able to find those needs met internally. Is that okay to say?
It's totally, yeah. I think that, you know, you think about some of these practices, particularly in rural areas where you're, you know, you're by yourself, or, you know, or you come out, I mean, like, there's a lot, like, you know, to Ezra's point, there's a lot of stress on the shoulders of junior faculty, you know, at least in a large academic center, especially if you trained there. You know, the people who trained you are there to back you up, and you're just always like looking. I remember always like looking behind my shoulder for the first couple of years and being like, I can't get into this portal vein, or I can't get into this bile duct, and like somebody who was like way better than me would come and help me. But that's not the scenario. We don't have the luxury of always like, you know, getting an extra few years of training by staying on. I think about some of my fellows I've trained, and they're going out in community practices where they're by themselves, and they're like, I'm going to start PAD. And I'm like, well, I didn't teach you PAD, or I'm going to do aortic interventions. And you're like, oh my goodness, you only like saw like a couple of EVARs with vascular surgery. Oh, but there's a couple of courses I'm going to go to, and I'm going to learn vertebroplasty. It's a lot. And, you know, they're excited, you know, because they're going to bring this new thing to the practice, and they're going to pull their weight. And, you know, this is how we do it as IRs. We innovate, we push the envelope, but someone somewhere should be like, listen, like, you may have a bad thing happen, and that's okay. And if you do, call so-and-so, like call Herschel because he knows about G-tubes, or call Maureen because like she's definitely experienced like tunnel blind mishaps. But I'm serious. I think, to your point, that's actually how it becomes. And I'm sure you know that, like, as you get older, you find this crew of your colleagues, you know, because you can come home and tell your partner or your parents or your friends, but unless they are IR, they won't really understand what went on. They'll sympathize with you and they'll feel terrible. But boy, it's so nice when you call somebody who's been in the same shoes and you're like, you know, XYZ just happened. And they're like, oh my gosh, I've been there and I know how you feel. And so when this terrible complication happened, I went, and at the very end of the day, I called Ernie Ring, who's my mentor. And Ernie, whenever something bad would happen, he would always ask you, like, how old is the patient? That's the first question he would ask, because like, then he could, you know, because it would be terrible. And he would just be like, listen, like, that was, it was like a joke on his part to try to like make things light. But it's important to, like, when you hear like the Jim Beninati's or the Jim Spiezes or the Mike Darcy's of the world, they've had complications, and then you can talk to them, you know them well enough, or they're your sponsor or your mentor, and you can call them and you could say, like, this devastating thing happened to me. They can't make it okay, but that like connection can make you feel like, okay, you know, like I made a terrible error, but I'm going to learn from it, and this person's going to carry me through it. So I encourage that of everyone on this call, like to be humble and open and share, you know, and pick other people up, because it doesn't do anything to your reputation. It doesn't make you like a dangerous doctor or a bad person if you admit that you screwed up a couple of times, right? In fact, I think people will be able to, you know, like see you as their, you know, helper along the way.
Thanks, Dr. Coy. I guess I have another question. And if anyone else does, please type it or raise your hand. Actually, I'll go to Herschel because his hand's raised again.
That was an error. I'm trying to unraise my hand.
All right, well, Herschel hasn't just made an error.
It's a near miss. Or not clear.
We'll have to report
it. I'll mark it down. Do you give this talk to the trainees at UCSF or at UNC now, or a similar talk?
You know, it's a really good point. I have always back when I was at UCSF, I always met with the trainees when they first started, and I didn't give them this talk, but I went through like a stepwise of what to do, because we've had like devastating things happen where on call, like a post-haste patient expires or things like that. And I think like for me, like the most important thing is that check-in with the trainee or the junior faculty. And I think like the most I can do, like the most I try to do always is to try to normalize this by sharing them my own story and just letting them know why some people can be a little bizarre about certain procedures. Like I'm very bizarre about tunneled lines, right? I'm always in the room. Like it doesn't matter if it's June or if it's July, or you know what I'm saying? It's like, I will always be in the room, but I may just let you do a taste by yourself, you know, whereas I'm always in there. And so people have these weird like idiosyncrasies. You know, our diagnostic colleagues have it too. Like they miss a stroke and they're like calling everything. They're like, maybe there's some low attenuation and whatever. And not that I know what that would mean, but I think we all have that. And just to try to normalize it for them, and just let them know that it's gonna happen. It may not be as severe as the ones that, you know, Herschel or I experienced, but you're gonna do some bad, you know, and it just is about how you handle it, how you move on from it. In my opinion.
Great, thank you. And I certainly want to try to talk more about this kind of thing as an attending in the future with trainees. Dr. Ohoro, I see your hand raised.
Hi, thanks so much for the talk. I really appreciate it. I thought it was a really fabulous summary. Hi, my question is regarding M&Ms and complications. How do you actually track them? Do you use HiIQ? Do you have a homegrown database? Do you just have a spreadsheet? It's something we've been really struggling with.
Yeah, I think like HiIQ is a great data collection. It's just super expensive. So it's just dependent on whether the department wants to, you know, purchase that or not. I think more and more what's happening now is that the system, the hospital, the quality and safety folks who report ultimately up to the CMO have to track all of these. And there's certain things as a section or a department that you have to report, you know, line infections, for example, so CLABSI, upgrade of level of care to the ICU when unanticipated, you know, extended length of stay, things like that. So those get automatically tracked by the hospital through that. In terms of what we do, There are less costly reporting structures that I can discuss with you offline that you can employ to be able to track your complications and report them. But unfortunately, I think almost all of them rely on like one person to be able to do bookkeeping, which is why they're not as costly. So I think that going forwards, though, I think we're going to have a lot more light shed on complications and how it affected patients in terms of their stay, the cost, things like that, where there will be a reimbursement, difference if the complication was preventable and things like that. So I bet you that in a few years, we're going to have much more streamlined, standardized guidelines on how to report, which softwares to use, things like that. Like almost all of us use electronic medical records. So there's a lot of that that's coming down the pike.
If I could butt in here for a second, I think it's very important. I say this all the time, but I'll say it again. It's really important that interventional radiologists insert themselves in every process in the hospital. So from credentialing to quality to just about everything. But a really important place to be is to try to get on your patient care assessment committees, because they're the people that are going to be assessing your bad outcomes and deciding what gets reported and how things get recorded. So I would advocate greatly that you guys, anybody, get on as many committees that are running your world as is possible.
Agree.
So I have a quick question. First of all, it's great to see you, Maureen. I just was looking actually just last week at the registries that they have in surgery, specifically NSQIP. And we know that surgery reports all of their complications for every single case that they do as part of their registry system. I know SIR is in the early stages of working on this. Can you comment maybe on where are we as a specialty in terms of having a registry like this? And once we have it, how do you envision this will change our quality and safety structure in IR?
That's a really good question. I do want to tell you that I wasn't going to make this talk a lot about data, and I made it more about experience, but there's actually good level of data out there about how there's underreporting of complications, particularly as it applies to the surgical field. So just to have that in the back of your mind, which I think in terms of SIR registries, we are very excited about our first registry initiative, which is going to be called Vertex. And if you've been on the SIR, thank you. Okay, that just came up from Neil. And this is something that's in its very early stages, and it's going to have a lot of oncology things. It's going to have some musculoskeletal interventions. In terms of complications, that's not something that is in the phase 1 part of it. But if you think about it, we are really behind, and it makes us seem really bad. But I got to tell you, we're a brand new specialty. So that's sort of the cushion of all of this. But with Vertex, I think once we get it off the ground, which is a very expensive initiative, then another thing that we could do is bring in our complications and do documentation. I think one of the first things that we tried to do was employ the structured reports, which I think Neil may have commented on as well. And that's another way. We all need to speak the same language so that when we have the registry, we can pool the data and collect from it. But trying to get a bunch of IRs to do the same thing, is a tad bit challenging, I can tell you, from the foundation side at least. And we're really trying hard to get the Vertex registry off the ground. So, but I'm really hopeful, and I think you're very future oriented, and I think that our complications will be a part of our registry, but it probably won't be for the next few years.
So if I can, that was the meeting before this meeting. As the co-chair of the Structured Reporting Committee, let me promote, please, to you, both the Vertex registry, which There is a lot of support to help fund. The cost to the individual hospitals actually is remarkably low. It's a couple $100. It's really not that expensive. But to implement the structured reporting system is going to be how you can contribute to the registry once you sign up in a painless manner. If you implement the structured reports, PowerScribe, M-Modal, whatever reporting system you're using is going to help us just extract the data. And we are adding registry events to all of the updated structure reports so that we can just extract from your dictation all of the events, the outcomes, all that stuff, and it isn't painful and you won't bleed.
Thanks, Neil. Susan, do you have another question?
No, I didn't put my hand down from the
Oh,
last
no, no
time.
problem. I think it's a little bit after 8, so I think if anyone has another question, please ask it, but if not, we'll move on to cases shortly. Okay, well, I mean, Dr. Cohi, that was, I'd say it's a very powerful presentation, and I'm very happy that everyone got to hear it. And I don't know, I think it's something that we should talk about more and that we should, like we said, share with our trainees. So thank you so much for giving it and joining us today.
My pleasure. Thank you.
I would ask for you to stay on because we have case presentations.
Absolutely.
Thanks. So we have 3. I'll do an order of when I was contacted about the presentations. The first will be John Lee is going to present from BMC. So John, you can share your screen. Good to see you.
Hello. Hi, my name is John. I'm a PGY5 ESIR resident at Boston Medical Center, and today I have a case to present. So short HPI is that this is a 28-year-old female with no significant past medical history. She initially presented to outside hospital with a non-traumatic subarachnoid hemorrhage, likely secondary to mycotic aneurysm, endocarditis, and mitral valve vegetation. So for more care, she was transferred to Boston Medical Center. Of note, she said that she had a 1-month history of tooth pain before the initial presentation. So during the hospital course and initial workup and treatment, she complained of new epigastric abdominal pain, and then the CT abdomen and pelvis was subsequently obtained. So these are some key images from the CT. And as I scroll down, you can see that there's pseudoaneurysm coming off from the SMA branch. So since given her clinical picture, this was concerning for pseudoaneurysm, likely secondary to infection, mycotic aneurysm type. So primary team actually initially consulted both vascular surgery and interventional radiology for any treatment options. So we had extensive conversation with both the vascular surgery and patient and the patient's family members about the potential options of open surgery versus endovascular treatment. So subsequently, after knowing and understanding all the risks and benefits of both options, patient and the family decided for the endovascular procedure. So we first proceeded with the diagnostic mesenteric angiography. So the celiac access was obtained, and which showed the traditional anatomy with the unremarkable findings. And then on the SMA angiography, we noticed that there's a 2-centimeter pseudoaneurysm from the mid-SMA branch. So she was brought back to the IR room a week later for treatment. So this was selecting the SMA with the 5-branch SOS catheter. And then on this run, you can see that the 2-centimeter pseudoaneurysm is arising from the mid branch. However, on the delayed image, as you can see closely, there's another small pseudoaneurysm at the more distal branch of the SMA. So we have our findings, and then we use microcatheters to more selectively select the branches. So as you can see on this angiogram, we see the feeding vessel and then the pseudoaneurysm sac here. And then if you follow, you can see that there's a occlusion of this branch, and then there's a alternative pathway that goes up over to here to our second smaller pseudoaneurysm. So here we face another decision point for embolizing. Do we use a glue versus coil? And given high risk because of rupture and all the inflammatory changes around, and given her young age with no other significant past medical history, we decided that coil would be more safer option for this patient than glue. So we went and deployed 4 detachable Ruby coils on the dominant pseudoaneurysm, and then used microcatheter system to select our way into the more distal, smaller pseudoaneurysm. And at that point, under imaging guidance, we also was successfully able to coil the smaller one using the 2 detachable low-profile Ruby coils. So this is a final run on the SMA after the coil embolization, which shows that there's a complete occlusion of the 2 pseudoaneurysms that was found. So clinically following up, she had improved abdominal pain, and on serial abdominal imaging, she did not have any pain out of proportion to suggest any complications. Repeat CTA, we originally recommended a 3-month follow-up, however, was done about 2 days after the procedure because of her plan for cardiothoracic surgery for mitral valve repair, which was unremarkable. She got uneventful mitral valve repair and was discharged safely to home. So I think in line with our lecture topic today, I think there's 2 main points to be discussed, approach to problem. I think it's important that both vascular surgery and IR, as well as the patient and the family, all agree that interventional procedure was the first step, and then surgery would be there in case things didn't go as planned. So we had a primary plan as well as a backup plan, and everyone was on the agreement. And then the other point to also think about is the embolization material, given the young age of a patient, as well as potential complications with each embolization material. And thank you.
Great case, John. Those SMA pseudoaneurysms can be very challenging cases because you're very worried about the territory they supply. So that was very nice. Any questions for John about that case?
So we're using the phrase pseudoaneurysms. What was the etiology presumed to be?
So it was unclear. She had prior CT images without imaging findings on the like within a month period. So we all think this is attributed to her ongoing infection.
Okay.
Great. Jalil, is your hand raised to present or to ask a question?
Yeah, I just want to ask a question. John, were you concerned about bowel ischemia? And I guess the second question is for the audience. Is it okay to consider maybe putting a stent, like getting a cross and putting a stent, at least for the first aneurysm or pseudoaneurysm?
Yeah, definitely bowel ischemia was our biggest concern. And on our serial abdominal exam, she fortunately was not having any symptoms of bowel ischemia. And then also that was our primary reason to choose, because our attending and I thought it was more control with a precise deployment of the coils rather than using glue for the fear of potential complication.
We never could actually get across that occluded segment, and you know, I didn't want to stent across mycotic. You know, I thought that there's adjacent infection. I was worried about stenting, but wouldn't have been able to because couldn't cross that occlusion.
I have to say it was some fancy catheter work to get around into that second aneurysm. So it looked good.
I was super impressed. I would be so scared to put in a stent. Like I just for it to deploy right and get everything correct. I would be more worried about that. I think getting the coiling was amazing.
Awesome. Great case, John. Thank you very much for presenting. And then we have Jalil Kantari from Brigham has a case to present.
Right. Hello, everyone. My name is Jalil. I'm one of the interventional radiology residents, formerly known as fellows from Brigham and Women. I'm just bringing this up. Everyone can see this. Hopefully, yes. Okay, so disclaimer to this presentation is that today morning I was texting Ezra and I was like, you know what? I just remembered I had a very nice complication from a case back in the residency, and I figured to present this. So I'm going to present the coil-assisted antegrade transvenous obliteration. So history, this is a 54-year-old man with history of hypertension, diabetes, alcoholic cirrhosis, transferred from outside hospital with upper GI bleed and melena. Patient had already got 1 unit of packed red blood cell, had EGD showing grade 2, medium-sized distal esophageal varices, and also cardiofundal varices, and significant blood and clots in the stomach. Patient was already on PPI and already started on octreotide. For the sake of the time, you can see these gastric varices, and there's a nice gastrorenal shunt that you can see here. So we were consulted for placement of tips. So we evaluated this, and we said, oh, jumped. We started by getting a transhepatic portal access, got a micropuncture kit, upsize it to AccuStick, and with a 4-French with a glide wire to SMV. So this is the initial SIG. You can see the portogram, and then you can see the SMV and all the, the gastric vein and the gastric varices. So then we get to the right IJ and get a right hepatic vein, get to the right hepatic vein using a 5-French, the routine fashion with the Amplats, and advance it to IVC, and then upsize it to 10 French. And let's see from here, you can see the right hepatic vein, and we got access from the hepatic vein into the right portal vein with single stick with using column pinto needle, advanced the wire to main portal vein, and then got a 5-French glide catheter and glide wire to the SMV. So the initial portosystemic gradient was actually just 8. So you can see the single stick just got there. And so then we decided that we were going to do that. Well, not we just decided. Well, at this point, we got to a point of getting the antegrade transvenous obliteration of the gastric varices through the transhepatic access. We went to the left gastric vein with a 4-French glide catheter and a 035 glide wire. And then the glide catheter was pretty much distally placed. So you can see, well, yeah, distally placed given the flow. So, or you can think about centrally. And then using the right IJ access, we pretty much got into the proximal gastric vein, and use a microcatheter, Renegade STC and Transcend. And we pretty much coiled using interlock and micronester like that. So everything is good from this point, and you can see the other catheter we're using a coil assisted. So we have the coils, and then we have the catheter going beyond it from the transhepatic access. And here comes the complication. We injected gel foam slurry distally, and the coil pack migrated to the left from the left gastric vein into the portal vein. So let's see, and then I'm going to show you the image. So at this point, we pretty much pull back and put an Amplats plug in there to stop at least we embolize that part. And then what we did is that we used the transhepatic, upsize the transhepatic access to 8-French destination sheath, and then use a 10mm end snare and partially retrieve some of the coils. Approximately 2 of the coils were remaining that in the process of grabbing that bundle of coils, they migrated. You can see the images of where one it is. So it at least is not in the portal vein. So at this point, we decided that there's really no point of going further and trying to fish that out. So now that we are done with that, we noticed that the pressure portosystemic gradient was not 11. So you can see I already showed that. So now we went back to continue back to our what we were planning on, which was the tips. We angioplasty to 8mm Dorado balloon and put an 8 to 10mm by 8cm Viator. You can see the final image. So we use just the coils just to close our access, and these are the migrated coils in the distal branches of the portal vein. I actually did reach out today morning when I decided to create this, to reach out to my attending. It's interesting. I made this presentation at the time, but as a junior resident, I never asked that question. Why anterograde? Why not retrograde? Unfortunately, I still haven't heard back. It's California time. It was Loma Linda where this was placed. So I don't have an answer. If you're going to ask me why was retrograde not considered, but I wish I had the answer for that. Thank you for your time.
Thank you, Gilles. Looks very challenging. Oh, Dr. Cohi.
I was just congratulating him.
Oh, thank you.
Great. Any questions?
Those are never easy. So, I mean, I think they're really hard to figure out. Like, I don't know. There is no magic bullet.
Well, you'll get to choose, Jalil, in a couple months when you're doing these on your own.
Yes.
Then we'll move on to Dr. Halen has a presentation. And Jalil, will you stop?
Jalil needs to stop sharing.
Let's see.
Up top, stop sharing. Up top in the middle, should activate a little bar.
Has a pause share, but it doesn't have the stop sharing. That's interesting.
Where
I
did
can
you?
see if I can request it for you.
All right, here we go.
Should be up at the top under view options or right by that bar. It should say stop sharing. Not, it should be in the middle on the Zoom bar, not on the PowerPoint bar. Mouse up to the top and the bar should appear magically all the way up. Herschel,
I'll get out of this, so this way we'll stop. Actually, you know what? I see it here.
There it is. Okay, this is just a fun case. So everybody see that? So case is swollen head. This is a 63-year-old male. It was referred to me. He's a past medical history. He's got CAD and he's had DVT and PE and CVA and chronic Lyme and hypertension. He presented with SVC syndrome and recurrent bacteremia and Bell's palsy, and he had a stroke, and he has pacemaker leads in place. I asked the EP people. He was just sent to me from an outside hospital with recurrent SVC syndrome. We sent him to EP because we knew he had pacemaker leads in place. That makes me nervous. And they interrogated the pacemaker, and they told me it was 99% non-paced. Not 99.9, but 99% non-paced. His hypercoagulability workup had been non-specific. And when he had been treated for his DVT and his PE, he had had a catastrophic bleed on a Rickstra with 4-compartment fasciotomy of his calf, which ended up in an AKA. So when you talk about everything heading downhill, this man had, every time someone touches this man, something bad happens. When he had been anticoagulated, he had a large and spontaneous inferior epigastric bleed with a big rectus sheath bleed, and they embolized his inferior epigastric. So he presented to me. He had treated an outside hospital, and this is from 2012, where you can see that someone has put a stent in the left brachiocephalic vein, kind of an interesting position, but already some problems with the right brachiocephalic upper SVC. And he eventually in 2013 grew pacemaker wires, which resulted in some further stenoses. So in 2020 at the outside hospital, he grew a wall stent. And it's an interesting configuration. The wall stent is actually extrinsic to the wires. Obviously, the wires are outside the wall stent, and the nitinol stent abuts the wall stent. And you can already see here the width of the wall stent at the atrial end and the narrowing at the top. There were some efforts made. At this point, he had SVC syndrome, and there was imaging, and he had developed intimal hyperplasia at the top of the stent, showing the fact that the right side's not draining here. It was draining a bit across to the left side. And there were efforts made to reconnect the SVC, brachiocephalic vein, and the upper right side of the venous system that were partially successful. There were some balloons up across from the subclavian to the jugular, and then a connection of the brachiocephalic stent complex into what's ultimately the EJ, and he felt better for a while. Here's the balloon blowing up. So he came back in 2020. He's now profoundly SVC syndrome-ish, and this is the outside hospital image. Terrible intramural hyperplasia in the wall stent, and you can look at the top and you can see that the wall stent's kind of crushed at the top. So this is a CT scan showing that here's the wires coming in, and everything comes to a screeching halt at the top of this stent. There's maybe a trickle through here. There wasn't on the catheter-based study, but everything doesn't look good. And this is the top of the wall stent. You can see that it's really narrowed at the top. This is just crushed down by scarring. And what's really, really cool here is that the two pacemaker wires are strategically placed between the nitinol stent that's in the left side and the SVC stent. Couldn't have done that if you had tried. So the blood flow has to be through the nitinol stent, around the wires, through the wall stent, back into the SVC. So he came to us, and the plan was, I saw him like we see everybody in the clinic as a Zoom patient. We planned revision as an outpatient, but prior to that, he really crumped. He ended up in the ED with severe SVC syndrome, was admitted to medicine, and anticoagulated. The medicine attending that admitted him was a nephrologist who immediately had a psychic freak out and had to get ophthalmology involved because she was sure he had proptosis and optic disc edema and all kinds of other things that I had to assure her he didn't have. But he was anticoagulated, and we did another CTV. And now there's nothing in the top part of the stent. It's really crushed off. And again, those pacemaker wires are right in the middle of the way here. So he had complaints. He didn't feel well. There were no EKG changes with his chest pain. And we talked to his pacemaker again and again. It wasn't doing very much, so we brought him in urgently. And the first thing I did was go over to the left because it was the easier thing to do. We got onto the left, imaged it. It was kind of hard to get there. and it was clear that there were a bunch of webs in this wall stent. Intima had grown up around this wall stent. So got a wire across, got a catheter across, blew up a balloon. And you can see this lovely appearance of the pacemaker wires as I blew up the balloon between the two of them. This elicited a lot of very interesting dysrhythmias, which made anesthesia nervous, but his pacemaker didn't fire, so we were happy. And we made the flow look like that, which was nice. We went to attack the top part. This is a venogram from his right arm. Nothing's going down. Again, the EJ's up here. There's a little string of an IJ eventually. But the top of the wall stent's pretty crushed. And this is what it looks like at the top. So I was able to get up from the arm up into that area. And we came up and I tried the normal glide wire, back of the glide wire, stiff glide wire, back of the stiff glide wire, back of the glide wire advantage, CXI through a sheath with the glide wire, all the stuff we normally do, couldn't get through, and finally brought out the RF hot wire and burned my way up here and grabbed it. And it turned out that we were through the wall. So I had gone through the interstices. And I tried to fix that. And in the past, we've been able to just blow open the side of the wall stents, but I broke 4 balloons, including 2 of the Conquest 40s, trying to tear open the stent. So I gave that up and came up, and using the sheath and a balloon to center myself, I actually got out the top. This is the RF hot wire, and burned through the center of the stent, grabbed it, pulled it across, and this is the balloon then able to actually expand the stent at the top, ping, and now reestablishing flow. A lot of intimal hyperplasia. We did a bunch of angioplasty. There was a bunch of clot that had developed in here, and eventually ran a POSIS through here a couple times, cleaned out the clot. I wanted to re-stent this, and the dilemma became, do I do a double barrel stent here, or do I just fix the spot from the top of the nitinol stent to just outside here, which is what I really wanted to do. That was 4 centimeters, and all I had was 5 centimeter stents. So we got him open, got things flowing, and put him on dual antiplatelet agents and Lovenox. We were going to send him home, and then we just said the heck with it. And he's coming in tomorrow morning. He's in the hospital. He's coming in tomorrow morning, and we're going to put a 4 centimeter stent in and see if I can keep him going. I did kind of go out on a limb and put a drug-eluting balloon in there to try to push back a little of the intimal hyperplasia, so we'll see. I think that ultimately he may eventually end up with double barrel Viabons, but just an interesting case of what happens. Some of the things that happen when we decide to be cowboys and try to fix everything, and maybe not always make the best decisions. So.
Neil, how's he doing after your first intervention?
I went and saw him later we finished that at about 8:30 at night. I saw him the next morning. He was spectacular. His arm had deflated, his face had deflated. A lot of the injection in his sclera was down. So he was wonderful, and he has luckily stayed that way. And as I said, we're going to hopefully stick a venous stent in him tomorrow in an attempt to keep him open for a while.
Awesome. Okay. And then Jaleel has a question for you, it looks like.
Sure.
No, actually, I don't. I just can't get that on.
He just can't put his hand down.
Yeah, I can't put my hand down. That's the problem.
This is the difference between trainee and faculty. We have so learned to be on Zoom and like hand raise, hand down, share screen. So it is tricky. I just wanted to say that I love that case because I think that it's one of those cases that brings in immediate gratification because the patient, like the decompression is so quick. Patients feel so so great when things go well, but it is a hard case and kind of tricky. So well done.
And I want to say that I take these cases very seriously. We have had some really catastrophic bad outcomes from I'll use the word poor choices made during treatment attempts. And I have to say, I've been doing this a while, and I have learned. And you can be humbled by things that go poorly. The one thing I have learned is there's very little that works better than sitting with a patient or a family at the bedside when things go bad.
Thank you, Neil. Well, that's it for our case presentations. Dr. Coey, I'll ask you to award the best case award. I don't think that Dr. Hillen gets to be considered.
I don't count, not me.
So Dr. Kalantari or Dr. Lee, I'll ask you to deliberate and decide.
I'm usually like the collaborator that likes to have everybody be happy at all times. It's worked really well for my career. You know, I think our first case was really great, but I think Jalal's case, just because it's in the liver and the portal, and I think it was super awesome. So I would award him the best case. Although I wish we could split it and get 50-50.
Thank you for making the decision, though. We'll clap for Jalil. Oh, my phone's on. Okay.
Oh, nice. I
Yeah.
like that.
And then wait.
What's the next level of like Zooming meetings?
I think actually our president last year, Aaron Harmon, introduced it. So every once in a while I break it out. But I guess the next time I break it out is for you. So thank you for presenting. It was wonderful. And thanks everyone for joining. And our next meeting is April 12th. Dr. Janice Newsom from Emory is going to speak on IR management of trauma. So another great topic. So thanks again.
Everybody, please remember to fill out your surveys on EADS. Remember, everybody to sign into EADS, and please sign your surveys so that you get your CMEs.
Thank you so much for inviting me again. This was super fun.
Thanks, Dr. Good night.
Thank you so much.